Thank you very much for that. Good morning, everybody. Welcome. It's great to see so many of you here. I'd like to thank CACI and HFMA for putting on such a great event. My name's Chris Walters, and as of the 1st of April, I am the Director of Pricing and Costing for joint NHS England and NHS Improvement. I've got a few introductory remarks about moving beyond the NHS's 70th birthday and how costing can support local health economies. Last year, my colleague Ben Dyson spoke at this conference about the challenges facing NHS organisations, increasing demand and financial pressures, and I think it's fair to say that those have continued since Ben spoke and look set to continue for the foreseeable future. Ben also spoke about the importance of delivering good quality, detailed costing information to address those challenges. So addressing those challenges through understanding how resources are used to treat patients, by benchmarking performance between services so that organisations can share best practice, and to inform decision making on how we redesign services. Patient level information and costing systems, PLICs, we see providing that detailed quality costing information. And we've been working with you, with providers, over the last 3 years on our costing transformation programme to roll out PLICs in a consistent way, ensuring that all trusts have access to PLICs and can use it in their decision making. So today I'll give an update on 3 key developments since Ben last spoke and some future developments, and I'll do that by describing 3 wider contextual factors and 3 slightly narrower contextual factors. The wider contextual factors are the NHS's 70th birthday celebrations and the public discourse around that. The 5-year funding settlement that came out of the spending review following that NHS 70 birthday celebration, and the publication earlier this year of the NHS long-term plan. And the 3 slightly narrower contextual factors are operational planning guidance, which was published in December, the development of integrated care systems, ICSs, which continues, and then the coming together of NHS England and NHS Improvement to work as one unified organisation. And when I've done that, I'll reflect on how PLICs and costing can support the continued challenges within that wider and narrower context. Before handing over to Jack, my colleague Jack Hardman here, will speak in a bit more detail about our priorities for the costing transformation programme going forward. So to come on to the first of those wider contextual factors, the NHS's 70th birthday, that was a time where I think as a nation we reflected with tremendous pride on what the National Health Service has achieved. But you'll also remember it elevated to an even greater level, if that's possible, the public discourse around funding, around staffing, around health inequalities, and around demographic changes. And the pressures on the NHS will continue in light of those factors. It's only really the Brexit that's keeping the NHS off the front pages at the moment, and that's not going to continue forever. Well, presumably that's not going to continue forever. So the eyes of the country will be watching the National Health Service in the near future, and we need to be ready to meet those challenges. The second wider contextual factor is the 5-year funding settlement that followed the NHS's 70th birthday. That was an additional £20 billion of funding by 2023-24, which effectively restores the long-run rate of funding growth of the National Health Service to its trend level, which I think is a good thing, of course. But demand continues to increase as well, and that means we can't lose our focus on efficiency. The long-term financial settlement will certainly help put the NHS on a more sustainable long-term footing, but we must use costing data to drive more efficiency in the National Health Service. As with all public funds, we need to ensure we can secure value from those funds, and we need to use those funds to provide efficient and safe and effective patient care. To do that, of course, we need to know how our resources are being used, and PLICs can give us some of that information. That presents us with a great opportunity, I think, but in order to seize that opportunity, we need to be proactive and innovative about how we're using PLICs data. Now, there are exemplars here in the room, providers who've done a great work on that. I'm thinking in particular Wrightington, Wigan and Leeds Teaching Hospital, and I would urge you to connect with those colleagues and to learn some of the lessons from their innovative and proactive use of costing data. And the third wider contextual factor is the NHS long-term plan, which looks forward from the NHS's 70th birthday towards its 80th birthday. The plan built on the approach of the 5-year forward view. It was developed by those in the National Health Service, including arm's length bodies, by the public, and by others with an interest in the National Health Service. There are 6 key themes from the long-term plan: developing a new service model for the 21st century, more action on prevention and health inequalities, further progress on care quality and outcomes, ensuring that NHS staff get the backing that they need, mainstreaming digitally enabled care across the service, and ensuring that taxpayers' investment is used to maximum effect. And in my view, good quality costing data underpins most, if not all, of the themes in the long-term plan. And we'll need to see further changes in service delivery to meet those 6 themes, meet those ambitions, address those 6 themes in the plan. And to do that, I think we need to understand the costs and impacts of changes which we can implement sustainably, and I think that's where PLIX feeds in. Moving on to the 3 narrower contextual factors, I think the first of those is our operational planning guidance, which was published on the 22nd of December as a wonderful Christmas gift to you all on behalf of the central bodies. It sets foundations for proposed changes to the financial framework to support the long-term plan. The key theme that emerges from that is that we are looking to move away from individual organisational control totals to better support system working, including agreement on a coherent system-level operating plan from individual providers and CCGs. That also foreshadows changes to the National Tariff Payment System, which took effect on the 1st of April, including the introduction of what we're calling blended payment for urgent and emergency care, which is something that we see as breaking down this false dichotomy between purely click-of-the-turnstile activity-based payment and block contracts. We see blended payment as something that's in the middle that can capture the best of the different pricing models. That's been used in a similar form in mental health and in about half a dozen ICS areas, and it's now firmly embedded within the tariff. And over the next couple of years, I think we should expect to see blended payment models being extended to other care areas. I've been asked whether the tariff remains relevant in an era of emerging system controls, and whether the introduction of blended payment reduces the need for costing, but I think it's completely the opposite. I think, if anything, it increases the need for costing information in order for us to be appropriately assess the true cost of care. The operational planning guidance also includes a further efficiency target of 1.1%, and understanding what it costs to deliver services and where variation exists between organisations in the cost of delivering services is obviously extremely relevant, and PLIX is extremely relevant to that, better quality costing data. That's why PLIX underpins things like the Getting It Right First Time programme, GIRFT, the Model Hospital and Right Care. These changes will need closer cooperation between commissioners and providers and good local data to understand the costs of care. So the second narrower contextual factor is the development of integrated care systems. These are designed to provide better support to deliver more joined-up care. We've expanded from 6 areas now to 14. NHS Improvement and NHS England have been working with ICSs to develop services, governance models and payment models to deliver care that's needed by the local populations in those ICSs. We'll hear later from Nottinghamshire ICS on its pilot to join up information across the ICS, which I think is a great exemplar of how costing can support integrated care system development. And the third narrower contextual factor is the joint working, the coming together of NHS England and NHS Improvement. Just as we're exhorting the frontline and the local health systems to work more closely together, we are practicing what we preach, and we are working more closely together. It's important to emphasise that the coming together of NHS England and NHS Improvement does not affect cost collections or anything for 2019, so please carry on as you are. The changes to NHS England and NHS Improvement's joint working are still in train, but I think you should see more joint regional teams, more joint executive appointments, and a continuation of other joint working initiatives. In terms of costing and the payment system, that is already, for many years, that was and has been a joint, a common and shared endeavour between NHS England and NHS Improvement. So in this particular area, the coming together of the two organisations doesn't really affect things a great deal. In fact, the joint working by NHS England and NHS Improvement was exemplified through our work on costing and our work on the pricing system. And some joint appointments have already been announced. Mine is a joint appointment, for example, and you'll know more about your regional contacts pretty soon, I think. So within the context of those wider and narrower factors, how do I think costing can support the changes that will continue, the challenges that continue to be the case throughout 2019 for the National Health Service? All those changes, the long-term plan, the financial framework, different operational models at national and local level create the need to change the way we work, and therefore they require an investment of time. We're being asked to look differently at the way we deliver services and the way we view healthcare, and to do that as much as possible, even more from the patient's perspective. That reinforces the need for reliable, quality information across the National Health Service, so we understand how we care for patients, what pathways involve, where patients are best treated, and how much it costs to deliver that care. In an era of integrated care where pathways cross organisational boundaries, we need to continue to understand the cost of delivering care across multiple settings. That's impact on patients and understanding the value of delivering care in different settings. We need to make decisions that are based on appropriate information at the right level of detail. We need to be able to compare performance between providers to continually improve. PLIX underpins all that. PLIX starts with the patient. It brings together information about patient care and costs into one place, making it a valuable tool for clinicians and managers to inform decisions. In doing so, it supports better reporting, bringing cost information on activity and cost into one place, better benchmarking by comparing activity between clinicians, between teams, between services, or even between organisations, and it supports better decisions through flexibility and granularity to allow better modelling and planning. That's it from me. Thank you very much, and I'll hand over to Jack now, who'll give you a bit more detail about the Costing Transformation Programme for 2019. Thank you very much for your time.
Thank you. Good morning, everybody. Apologies to some in the room. This will be the third time in 3 weeks that you've seen me. Some nods, yes. You probably see me, then you see your own mother or something like that. But don't worry, I'm sure a question will come. We've got Chris Walters on stage. If somebody wants to ask about the new Director of Costing, they're more than welcome to. So first and foremost, from myself, from Candice and the rest of the costing team, thank you to everybody in the room. We know it's been a struggle this last few years, but we're finally on that pathway. We're all together. This year will be the first mandatory year for the acutes in the room. And hopefully you've been on that journey since 3 years ago. We keep on releasing a number of different tools. The team's there to help you out. We're on this together. It's absolutely important that we keep speaking to you and you keep speaking to us. In 2018, we had 121 submissions across everybody, and that's for a voluntary year, so really well done to yourselves. Of those 121, 80 were acute. Thank you to those 80, because it meant that we could reconcile to reference costs, and we managed to turn that IP, OP, A&E reference cost submission off, because we can use your PLIX data through the data validation tool to fill that part of the workbook out. What that means is over the next 18 months to 2 years, hopefully shorter, we can start to move the things like the unbundled section into the CTP programme as well. It's because it will be our first mandatory year, we've got a number of different tools which I'll talk about in a minute to help you as well. Now, it's been very, very silent other than some clapping, quick audience participation. If I say NCC, what does that stand for? Fantastic, it's getting out there, well done. National Cost Collection. So in short, what we've done is we're trying to sort of rebrand a little bit here. So CTP, Cost Transformation Programme, you go out into your organisation and you mention that, it means nothing. People are like, I don't understand. You mention reference cost and you've got clinicians going, yes, I know exactly what reference cost is. That informs tariff, it informs payments, etc. Yes, they've got several years on CTP, but this is where we're going. So the National Cost Collection not only takes CTP PLIX, but it also takes the reference cost elements and brings that in. So your NCC is your annual collection. That's what we're going to be using to inform tariff, etc. within the future. We'll feed back into the portal through different programs. That's what we want to use. So it's great to hear a lot of you sort of come back and say, yes, National Cost Collection, fantastic. So moving forward into this year, we're redoing the CAT tool. That's where you can put your information into the spreadsheet. It will feed back and give you and your peers a score. It's absolutely fantastic and vital bit of kit. that you can use internally. It's not something to push you down or check what you are doing. It's to help you and help inform what you need internally from your organisation. Everybody in this room has done the right thing by coming today. You want to do better. Unfortunately, we know that some of your higher-ups don't always support you. We've heard stories of costing teams being shoved right to the back of trusts, right to the back of the hospital where the mortuary is. We don't want that. We want you to be front and centre. We actually want you to be pivotal. It's true, it's very sad. We've re-released the Plix portal in December. For the 80 acute trusts that have access, please do look at it, please do feed back to us. It's completely new. We've scrapped the old tool, we've moved forward. We're going to do a relaunch late May, hopefully touch wood, all being well, where we'll continue with that story. So we'll make sure that within about 4 clicks, you're really getting to the information that you need, which can really drive change within your organisation. The data itself is being used widely across NHS Improvement. So we have our colleague from Model Hospital about to talk. The number of requests are coming in weekly from the GIRF team to get access to your information, use of resources. This is where your data's going. Some of those that came to our regional forums will have seen our economics team talk about the work that they're doing on things like cancer pathways, length of stays. It's really nice to see your data being used. It's gone are the times sort of 10 years ago when I first started, when it went up to the centre and never came back. It really is being used. So please do stay in touch. If you want to hear about these things, drop an email to the costing inbox. And we'll happily send any information that we've got back to you. We also launched the public portal. That's been really well received by clinicians, commissioners, and just the general public. We have that online. Anybody freely and happily can use it. But what we also are wanting to do, we're working with information governance to start producing downloadable spreadsheets, much like you will have had before in reference cost times, a very high level, aggregated level that you can download and put into whatever system you want to, model it however you see fit, so you don't lose that information. It will be based upon that NCC Plix collection, but that's absolutely fine because what we're hoping is that will be more accurate running into the future. We published in February the integrated standards. So if you are an integrated provider, we don't want you looking at 3 or 4 different bits of information. We want you to be looking at a central bit. That will continue to develop over the next 12 months. It's absolutely key because the majority of you are not just acute. You are acute and community, or mental health and community. So we want to make it as easy as possible. We don't want to give you a 600-page document and another 400-page document. We're trying to get it together to make it as easy as possible. I mentioned before some other things that we're doing for you. So it's the supporting tools that we've got there. We've got the online learning platform. We've updated the courses on there. Please do log in. If you don't have a login, get in contact with us. We'll get you signed up. We've got some fantastic courses on there which take you from the real basics right through to where you should be towards the July time when you're submitting, because of course everyone in the room is submitting in July and not waiting till August. Thank you very much. We have the call surgeries. This is happening weekly at the moment, but when we start in the middle of June and the window opens, they will run daily. Please do use that surgery. We have specific surgeries for the different providers. On there will be one of the team who can answer your questions. If for some reason they can't, because it's something specific like the data validation tool, they'll know exactly who to call. They'll call that person. They'll make sure you get the information as soon as possible. Even if you just want to call for a chat, please drop them a line. Someone like Sarah Tyres will be on there. And she'll happily go, how's you? How's the family? It's absolutely fine. We just want to make sure you're ready to go. And on that, Catherine's already mentioned it. Right here is a network. We've got the regional forums that we run. You've got your supplier networks. It is vitally important that you make a friend today, someone that you've never spoken to before. We help each other out. There are a number of the costing team here today. Please come and say hello at our stand. That's not everybody. Some are back at home base. They've actually got a day job to do where we're having fun. But please, you will help each other out quicker than we can. the majority of the time, because you will find someone who's on the same system as you that's having the same problem or had the same problem, and it'll be a lot easier to speak to them, and you'll get an answer there on the phone, and potentially we might have to go away and check something. You, like I say, are vital to this process. Your colleagues are vital to that process. Keep on making, keep on making that network happen. And with that, that is a very kind of brief overview, just because we've heard a lot from Chris, and I want to give Chris Rye, our model hospital colleague, a lot of time to, not a lot of time anymore, apologies, I always chat, to actually present and show the good stuff and talk about the future and what Model Hospital are doing. So thank you.
Thanks, Jack. Thanks, Chris. I just wanted to start this presentation by just re-emphasising the link there, touching on things that Catherine mentioned at the start. The model hospital being an example of trying to help you make that bridge between good costing data and the value, the increased patient outcomes. Model hospital, among various other programs, GIRFT, Right Care, etc., all trying to make that bridge, and it's the same bridges you're building in your trusts as well, that link between finance and the outcomes for the patients, that being vital to make intelligent and data-driven decisions. I'm hoping you're reasonably familiar with Model Hospital. Just a very quick show of hands, if I can, people who have heard of Model Hospital. People who have been on Model Hospital. People who have been on Model Hospital a lot. People who like Model Hospital. Okay. So Model Hospital and operational productivity as was started from the Carter Review, a similar kind of time scheme about 3 years ago as the Costing for Value Institute started up and also the CTP really got going. Again, quite interesting to see how that's come. I'm going to show you a few things that we're doing on Model Hospital, and then I'm going to briefly speculate about the kind of things that we are thinking of doing and how it feeds into those things that Chris mentioned around the long-term plan. But really all our plans there do come back to that same thing, which is how can we help you get to that value, and how can we help you both network with each other, but also compare versus each other and get a better idea of what might be in future and how you can get there. So on the slide now is a kind of improvement cycle as we have it. This will be familiar to, again, those of you that I've spoken to over the last couple of weeks. But again, not a kind of radical thing, just the idea of improvement as a cycle, an identifying of things that could be better, usually via benchmarking or comparison to other areas, both within your trusts and within other trusts. But then the nitty-gritty of it, the more important part that we're working on as Model Hospital, as in NHS Improvement and NHS England, is the so what, the what next, the what do I do, the who do I talk to, that really lets you take the next steps towards making those changes. There's making the changes, and then there's reassessing what you did and working out if it's worked. And then you move on into that eternal cycle of what's next, what's the next thing, how can we make it a bit better again, and keep going. So we've tried to work on this in Model Hospital, especially the last year, based on user feedback we received. We heard, I don't understand these metrics, I'm not sure where they've come from. So we're trying increasingly to put on case studies, guidance, contacts within Model Hospital. I was speaking at an event last week, and a gentleman was telling me that a certain number of metrics related to ESR data wasn't, the metadata there wasn't on point. It wasn't helping him to know exactly what he was looking at. I've taken that away, and we're working on that now. But just again, that continuous improvement to make sure that what you're seeing relates as best as can be known to your reality on the ground, so that you can know what to do with that information you're seeing. Very briefly on recent key features of Model Hospital. So we've last year we created these opportunities. They're currently reference cost driven. Some of you have mentioned that that's not ideal. I would agree with you, and I would look forward to using PLIX data for opportunities, but also throughout Model Hospital to really kind of turbocharge it, make those metrics a lot more accurate and a lot more real, in the same way that PLIX represents a detailed and truer picture than reference cost does. Notifications, recommended peers, user resources assessments, all these things being supported by Model Hospital, and all requiring the best data to be most useful. And again, all of these things will be better with PLIX, as you will know from your own experience using PLIX data in your providers. Various different areas of Model Hospital, trying to reflect the various different things that go on in your trust, but also presenting back to that big picture that all these different areas of hospitals, all the different things people are doing are all either directly or indirectly focused on the patient benefit, and most assuredly everything that is done has a cost that you're helping to quantify. New compartment on Model Hospital, as an example, quality, diversion, inclusion, working with NHS England's RES team. Again, an example of information that will be interesting to certain people in your trust, and also kind of contextually informs wider questions about staff mix, etc. Another one that's coming soon is around digital data and technology. Again, you'll know much better than me the limitations that the current data situation within your trust, system compatibility, etc., those limits that has on your costing, and therefore that limits the understanding within the hospital of exactly what's going on in different departments. This one, again, just assembling the data and showing you where you are, who's doing different things. Another thing we've worked on quite hard is different sectors. Carter report was on acute, non-specialist acute, in fact. We've tried really hard to roll out new compartments, catering to ambulance trusts, mental health trusts, community health trusts. There's a especially important one to mention because in addition to catering for those areas, it also preps us up to recognise what was true at the start also, that all trusts are increasingly, back then most trusts had a community health element, and increasingly, as Chris mentioned, with STPs and ICSs, these patients are being seen across systems. You're offering different services, and also different providers are offering different services. And PLIX, again, a golden thread potentially of tracking those patients as they move through the system and getting an idea both of their journey, but again, back to the original, what's it costing and where might it cost differently, but also what value are they getting from different places, and how can those organisations talk with each other so that journey is smoother, more effective for the patient, and potentially also more efficient and cheaper for the system also. We've also got some trust ambassador program where we try and build local champions in your trust. Some of you will be ambassadors. Hopefully some of you will know who the ambassador in your trust is. Again, a kind of point person, similar to you'll have a clinical champion or a kind of critical friend in a service. These are just trying to get knowledge and awareness of Model Hospital out into the world for people to engage with and use the data. Lots of different help avenues for Model Hospital, which again, please do engage with us and let us know what we're not doing right, what we could do better, and we'll try and be better, I guess. Some links there, but just to close, Model Hospital, GIRFT, Right Care, the Quality Improvement Team within NHS Improvement and NHS England, all now as part of joint working more together under an improvement kind of collective. And the links between those will mirror the links that you're building with other providers, and hopefully a more kind of comprehensive and thorough support offering to you, so that helps back on the improvement cycle, helps you make contact with others, helps you know what other people are doing, so you can take a look at it and work out if that might work for you as well. But really just get everyone talking with each other, and with Plix and your help, a good sight on costing and value together is going to be critical to addressing the challenges that we're all facing.